Hey, so we're back again talking about another Southwest Ohio pre-hospital care protocol. These again come from the Academy of Medicine Cincinnati Protocols for Southwest Ohio Pre-Hospital Care. All the folks that are responsible for this set are listed on that thing. I again will note that they are friends, but not specifically associated with EMS Grand Rounds. This is provided as a service for you folks that may be using them out there. And if you're not using them, you should check them out. They are pretty comprehensive. They're reviewed on a monthly basis. And pretty well are up to date. Good set of protocols if you are looking for something to adopt and generally meet with the highest level of pre-hospital care. What we're going to cover today is the M413 hyperthermia and heat-related emergencies protocol. If you remember last time on EMS Grand Rounds, we talked about heat emergencies, specifically heat stroke. So I thought we'd go back and hit it again real quick, this time with a review of the actual Southwest Ohio protocol. If you're on these protocols, this is what's in place right now. If you're not on these protocols, then it maybe gives you something to go on if you're trying to write a protocol. And again, we'll kind of hit on the little nuances of it as we go through there. So start from the top. The inclusion criteria. This is again for M413, the hyperthermia and heat-related emergencies protocol. So who's included in this? Well, we're going to use the treatment. We're going to use the protocol for patients of essentially all age. If you are a mammal, you can develop heat stroke in this way. There are certain high-risk groups for heat illnesses. The elderly and babies tend to be the ones that suffer from classic heat stroke. Classic heat stroke is you're exposed to heat for a long period of time, and it eventually overwhelms your body's ability to thermoregulate. So this is when, like over the summer here, there's been a heat wave in India that's killed a lot of people. But it happens over the course of like 4 or 5 days of exposure to heat, kind of more subacute or chronic exposure to heat that just overwhelms your body's ability to get rid of it. That typically happens in, again, the very old and the very young. Exertional heat stroke, which happens over the course of an hour or a couple of hours, tends to be folks that either can't or won't stop vigorous exercise in an environment where they are not able to lose heat fast enough. So athletes, kids doing football practice in the middle of August, for instance, military recruits, folks that are out working on the side of the road, those guys can have exertional heat stroke, which again happens over a period of hours. How are you going to treat them? Well, you're going to treat basically everybody exactly the same, but just FYI. There's also folks that have impaired ability to thermoregulate, such as folks with brittle diabetes, or folks that are on drugs such as antidepressants or some of the psychoactive drugs, or even Benadryl for a long period of time. Anybody that's got an infection, and folks that have CNS disorders, not only things like strokes, but anything that affects your central nervous system may also affect your ability to lose heat, or for that matter, to thermoregulate. And so subsequently, they can develop, they're more at risk for hyperthermia in even environments where the rest of us would be able to compensate fairly well. All right, so what are the physical findings that we're going to be looking for? Well, it can have pretty much any kind of presentation because we're looking at the whole gamut from mild sort of heat exhaustion, heat cramps, heat syncope, all the way up to heat stroke, which is a true medical emergency. So things like heat cramps and heat syncope are associated with somebody who's been exposed to heat and then either have muscle cramps, they may hyperventilate. Heat syncope is a thing, if you remember from last month's presentation, where the skin, as your body's big ability to lose heat, blood will shunt to the skin. If you're a little bit dehydrated or if you're a little bit hypovolemic, when all that blood shunts out to the skin and then you say like stand up and try to walk around, then you can develop syncope because you're relatively hypovolemic. So heat cramps, heat syncope, that's what happens. Heat exhaustion and heat stroke are really the big differentiator here. So heat exhaustion is your body saying, this sucks, we're getting hot, let's stop doing what we're doing and go someplace and get cold for a little bit. Bringing temperature down so that we don't progress to the dangerous area. Heat exhaustion can be accompanied with some volume depletion, so they may actually be somewhat dehydrated. You get fatigued, lightheaded, feel like you're going to pass out. You may get headache or tachycardia, hyperventilation. You can get some hypotension, and again, that's usually because you're shunting blood away from the central circulation and out into the periphery, so that you can so that you lose that heat. So you use your skin as a heat exchanger. Body temperature might be normal. It might be a little bit elevated. Either way, that's heat exhaustion. Heat stroke is a critical emergency, and it has to be dealt with rapidly. How are you going to know when someone has heat stroke? Well, they're going to have an elevated temperature, and that's defined as greater than 104 Fahrenheit, so 104 Fahrenheit. And encephalopathy or altered mental status in one way or another. So elevated temperature plus altered mental status is heat stroke, assuming that the clinical picture fits it as well. And what kind of altered mental status or neurological symptom could be almost anything. So you can have syncope, which again could just be heat syncope, but if they have the elevated temperature, then you're on to heat stroke. You could be truly irritable, or truly agitated, not just upset or uncomfortable, but truly altered. Be combative, have bizarre behavior, hallucinations. Any kind of stroke-like symptoms might be heat stroke in the right setting, something to watch out for. Seizures and coma and even posturing can occur as a result of heat stroke. So any neurological symptom, essentially, plus elevated temperature is heat stroke in the right clinical setting. That's not meningitis or fever or something like that. And then notes always made of the lack of sweating in heat stroke. Oh, somebody that's got heat stroke will have hot red skin, but they won't be sweating. That's actually not true. Especially folks that have exertional heat stroke, they may be covered in sweat from their head to their toes, but if they can't lose it fast enough and they're generating too much heat, then you'll see their temperature rise and they'll have heat stroke regardless. So sweating doesn't actually mean anything in terms of heat stroke. So if you want an easy-to-read infographic for this comes from the Raw Medicine guys, RAW Medicine. Check them out, rawmedicine.org. They have some good stuff, good podcast on austere medicine and care outside the normal bounds of where we think of delivering care. They kind of say the same thing that I said here, which is there's heat exhaustion, which is I'm a little hot and I feel bad, versus heat stroke, which is true altered mental status. And any kind of altered mental status plus elevated temperature gives you heat stroke that has to be dealt with quickly. So we've talked about the presenting signs and symptoms as well as who gets it. What's the actual protocol? Well, number one, you try to remove the patient from external heat sources. So that involves getting them out of the sun, which will provide radiative heat. If it's a hot room or a hot environment, or if it's hot outside, you try to go someplace where they're not gaining heat from the environment anymore. Often a good idea to remove the patient's clothing so that you can increase the amount of convective loss from their skin as well as from evaporation from their skin. The less insulation on the patient, the better. If you can get a temperature, good to document. Now, an oral temperature may or may not mean anything to you, especially if the patient's just had, a big sip of ice water. Their temperature may look normal or even hypothermic. Likewise, a skin or an axillary temperature, a tympanic temperature, not terribly reliable, although if it's what you got, it's what you got. A true core temperature, like a rectal temperature and esophageal temperature, is the best thing, but that may not be available to you in the field. So you should take a temperature. Something is better than nothing, most likely. So if you have it available, do it, but try to get a core temperature if at all possible. After that, you want to cool the patient quickly. And quickly means absolutely as fast as possible, because every minute that the patient has the altered mental status and the elevated temperature, you've probably got neurons dying in their brain. And you increase the chance that they're going to have a bad outcome. So you try to rapidly cool the person as fast as possible. There are several ways to do this. One of the classic ones is to toss the patient into a horse trough full of ice water. So if you were working a marathon or something like that, you may have this prepared for you, or if you're at a high school football game, this may be available. This may be something you can do. If you don't have that available, you can try to do convective heat loss. So you splash water on the patient and then try to provide some sort of air current over them to increase evaporation and increase convection. There's a note here about not covering the patient with wetted sheets. There is actually a technique to using wet sheets to cover the patient, but it involves having to rotate them around, having a fan blowing over top of it, and again, trying to move the water around so that it doesn't stay in one spot. You can actually do it, but it's technically somewhat challenging. The best thing you can do is undress the person and start applying water to them with some sort of air current moving over the top of them. There's a note about conductive cooling by putting ice bags on the axilla and in the groin. This actually is not as effective as you would think it would be. You can do it, but putting ice on top of the patient otherwise is probably a better idea than just putting it in the groin and in the axilla. and around the neck. You will drop patient's body temperature much faster if you put ice on top of and behind them rather than just on their groin, their axilla. So if you've got extra ice and you want to do that, that's fine. But you'll be better off if you just get the patient wet and then put that ice over top of their chest instead of putting it just on these areas here. And then there's a note about avoid cooling the patient so that they begin to shiver. Shiver may happen, and it's actually okay. If it comes down to his temperature is still 105 degrees, but he's shivering, then continue to try to cool the patient, because that's you're trying to lose the heat into the environment. For our ALS colleagues, you can give these folks IV fluid, especially if they appear dehydrated, although keep in mind that folks that have true heat stroke, ultramental status plus elevated body temperature may not be that dehydrated. I think the big point to make here is don't rely on saline to cool the person down, because if you took 2 liters of ice cold saline and put it into the person, you would drop their body temperature by about maybe a degree, possibly 2. Unfortunately, if their temperature is 108, you've now got them to 106, which is still too high. So cold saline may be useful if it's needed, but it can't be your primary driver. It can't be the thing that you're relying on. You've really got to get the convective cooling. You've got to get the conductive heat loss as much as possible. There's a note here that says if the patient begins to shiver, you can give them IM Versed or IV Versed if you have an IV established. I have personal feelings on that, but that's what the protocol says. Probably the shivering at most is going to increase the body temperature by about a half a degree if they can shiver that much. Clinically, that's somewhat irrelevant when what we should be doing is dropping their body temperature by several degrees at a time over the course of about 30 minutes or so. And honestly, that half a degree probably doesn't make a whole lot of difference. You got to watch too, because if you give them Versed, then their mental status will probably change a little bit as well. If you're going to give them IV fluid, normal saline is probably about the best thing in this case. You want to give them something that is at least isotonic or at least mildly hypertonic if you can. So D5 normal saline is a good choice. And then there's a note made that when the core temperature gets to 101, then you should discontinue cooling. And you may say, well, they still have an elevated body temperature at that point. And that's true. But the problem is when you get their temperature, their measurable temperature down to 101, as the rest of their body equilibrates, as they're going to continue to lose heat out into the environment, their temperature is probably going to drop down another 3 or 4 degrees or so. So if you wait until you get to a temperature of 98 degrees and then stop, their temperature is probably going to go down to about 94, which is colder than you really want. You'd like them to just stop around 98 or so. So once you get to 102, or in this case 101, discontinue your cooling so that you don't cool them off too much. So a few other notes are made here. They say there's no minimum body temperature for heat illnesses. And that's true when you talk about, especially like heat cramps, heat exhaustion, that kind of stuff. There is no like minimum body temperature they have to reach in order to get to that point. For heat stroke, I would probably argue that if your temperature is 100 degrees and you're severely altered, that's probably not actually heat stroke. Something else is probably going on. That's why the guidelines that you usually see will put the number at about 104, because under 104, other stuff could be going on that's causing you to get altered. Above 104, it's probably not. Now, again, that can be difficult to measure in the field, but just as an FYI, they do have to be kind of hot, at least 102, but 104 Fahrenheit is the classically agreed on definition for heat stroke. As I kind of mentioned before, many patients with heat stroke itself are not actually dehydrated. Folks with heat exhaustion might be, but folks with heat stroke often are not as dehydrated as you would kind of think and don't need 6 liters of IV fluid. They may need 1 or 2. There's another note made about shivering here. And about using benzodiazepines to stop shivering, and I'll avoid commenting on it, except to say, again, the shivering is probably not that big a deal, and if they start to shiver, just continue to cool them because your active cooling measures will be able to overcome whatever heat they've generated by shivering. And then last note again, core temperature can be difficult to assess in the pre-hospital setting. Just be aware that skin temperature, axillary temperature, oral temperature, tympanic scans or temporal scanners are not really reliable when it comes to the really elevated temperatures in these settings. So be very cautious when you're relying on them to make your diagnosis. But if you have it available, again, some temperature is probably better than none, as long as you're cognizant and cautious of the limitations that are there. So again, for further reading, I recommend the Raw Medicine website and the Raw Medicine podcast. They have a great infographic about this, and they do a great about 30 minutes on just heat exhaustion itself. And of note, the Wilderness Medical Society recently released an updated version of their heat illness guidelines, so check that out. It's good reading. It's not very difficult, and it gives you a deeper dive into some of the pathology on this stuff. So check it out, and we'll catch you next time.